Hello and welcome to this second episode in our series on realities of real-world evidence. In this first phase of the series, we are talking to leaders of medical departments of pharma companies to get a perspective on the opportunities and challenges of generating as well as using the real-world evidence. Today, we are privileged to have Dr. Akhilesh Sharma with us. He is President and Chief Medical Officer at Alkem Labs. He has over 30 years of very rich industry experience in global roles, both based in US as well as India. And he has experience across a wide spectrum of areas within pharma, clinical research, medical affairs, pharmacovigilance, translational medicine, etc. He's very passionate about innovation in clinical research and has over 50 publications as well as over 50 patents to his credit. Welcome, Dr. Sharma. Thanks for participating in the series, and we would love to hear from you. I have a couple of questions, and you can respond to those to provide us your perspective.
Thank you, and pleasure to be here with you, Dr. Chitra, and to really talk about the RW, give some perspective from certain of the experiences. Thank you.
Sure. So the first question is, how have you seen the interest in RWE evolve over the past decade or so? And if you could especially comment on the impact that it could have across the spectrum of products, including branded generics.
Okay, that's a very apt point to be addressed, especially when we talk about the evolution of the real-world evidence across the decade. So, based on the actual requirements and the patient journey, what it needs to be seen and needs to be addressed, and also what the drug approvals have seen over the past decade or little more than decade in terms of the safety as well as in terms of the overall effectiveness and drug utilization. It's becoming more and more imperative in terms of how the actual patient journey can be built into the drug development process, and that's how the evolution journey for RW really has begun. And over the last few years, we have seen the regulators adopting it and actually making it important as a part of the late phase study itself, so that it addresses a lot of the challenges which may come up later point in terms of safety. At the same time, upfront also it may provide certain advantages to the drug about the efficacy and the value demonstration, which may come much earlier in the development phase itself. So over a period of time, the RWE journey actually went from the post marketing to the clinical stage development, and it got embedded into it. Coming to the point about how the application would, in terms of across the branded generics or across the branded products, well, there's been a significant implementation and usage of real world evidence, and I would talk about mainly say for example a case study when I can mention about a branded generic for a product which actually was being used and is one of the topmost used proton pump inhibitor for the acid reflux phenomena, and which has been there for decades. And then a need was looked upon in terms of how one could really look at in improving or enhancing the patient experience about it. So on deploying a real world evidence study and using a proper data capture method, what was found for that particular drug is that the usage pattern was significantly different for a certain set of patients when it comes to different towns, in the country itself, across the towns, across some of the prescribing habits of the doctors. So that gave an idea about how one could look at bringing in uniformity in it so that the efficacy could be really translated through a proper set of practices, and also a long-term usage demonstrated the safety. So a data out of almost 160,000 patients, and this was not just India but even capturing it through a proper electronic data method and using the analytics tools which RW has really seen evolve over the past few years, has helped to cull down this data across these geographies in multiple types of patients with different co-prescription habits. And really, it provided a lot of inputs and information, and the impact on the brand, which actually was plateauing off, saw that uh, there was an impetus in terms of improving certain prescribing patterns. Like, say, for example, if it was being prescribed for 10 days or 21 days, instead of that, going there and providing information that in patients of, say, GERD or in patients of ulcer, the requirements of prescription would be much beyond, say, 6 weeks or 12 weeks. And then in certain patients where uh, it was seen if there could be some risk or some safety to be evaluated, the data also showed that over a long period of time, the drug really was being very well tolerated across the spectrum of patients, and at the same time identifying the patients where there could be certain safety risk at the same time. So this RWE data, which was used across these set of patients, really provided a boost to the brand as such. And we really saw a significant pick in not only the value, but the way the actual prescription pattern would work for the patients, and the way the patient adherence also improved after this data was being deployed through the promotional activities, through the marketing teams. So it makes a significant impact when we are using this. And I'm not talking about the late phase studies where already FDA and EMA are looking at having an RWE, and we all are aware about the value proposition of it. I'm talking about the impact it could create beyond the drugs which are already in the development.
Yeah, thanks. This was a great example of how useful RWE can be even for these types of products. Thanks for sharing that. So the next question I have is, good EHR data are often not very easy to find, especially in certain geographies, and we know in countries like India, for example. So when good EHR data are not available, doing real world studies becomes quite resource intensive, whether you do prospective or retrospective studies, in terms of the time they take and the budgets. In your experience, how are companies able to balance priorities across time and budget on one hand, and the importance of generating real world evidence on the other hand?
This is a very critical challenge which many of the companies face. And it's not only in this part of the world, but even in certain developed areas as well. Uh, when we talk about the EHR data being uniform, still there are differences in practices across the different states. Like you may see a uniformity of the way the EHR is being used, but you may see a difference in the way some of the recordings on the EHR happen across the states, even if the guidelines for a certain treatment would tend to remain the same. For example, I'll say pick US, I'll come to India later. In US itself, from a state to state, there are different ways in which the EHR data is collected, or the way it is written down. So accessing the data and then further extracting and getting the right uniformity of data itself becomes a challenge there. But then one needs to figure out that what are the key areas one has to really ensure. So that's how people have devised certain tools to pick what kind of data we are looking at. Coming to the other aspect in this part of the world, uh, we know that it's not a standardized EHR practice in the country to collect the data. So many of these clinic hospitals, they actually generally use records or charts, and then you have to look at the way the reviews would have to be done for this, especially when we are talking of a retrospective design study for the data collection. And the limitations could be that these may be incomplete or accurate, and even if the electronic medical records are there, uh, say for example in one big hospital to another big hospital, there may be differences in the way the EMRs are captured. So a prospective design study may include a robust data, but then the challenge here in the retrospective could be when we are especially trying to collect data, across, say, for example, the hospital registries or the records, and these challenges are in terms of interpreting and utilizing this data for the RW study, where we really want to use the data points to demonstrate, say, for example, efficacy, or if there an additional other usage pattern happening. And another is validity, like what is the validity of the data, the quality of the data. Most of the sources of these RW studies, where the data is collected to support the clinical care and reimbursement, these data are not gathered to support any specific research study. Hence, there are gaps in some accuracy, completeness, and quality of data. But at the same time, it could be confounding, like a small observed effect in an RW study could be due to some confounding factors in one records of an hospital into another records of a hospital. So I think important here is we need to consider certain factors when we are planning a real world study. And I believe the devil lies in the details, as we always say. So, how we decide, and we do some initial benchmarking of the data and then look at what kind of data we need to collect across the different data sets, and where can we converge this data to the requirement. Like, for example, if we are talking about I'll just give an example, because another study which we conducted was related to an NSAID, where we wanted to collate a data on the hepatic safety. So we could not really get a baseline data on the hepatic profile, and for sure nobody would do that, because that's not required when somebody is prescribing it. And then at the end of the study, only a few centers had the liver function test. So there was some sort of a discrepancy which we realized, and then we decided that what is it we can look at in the safety perspective. So the baseline safety assessment was done on the clinical examination and some of the findings, and if the patient had really some issues on liver, and if the patient was either included or excluded, and if there was data available or not. And at the end of the treatment, some of the centers which conducted the liver function test, they actually were included, and those patients' data was used. And then a stratification applied even within this data sets to see that based on the whatever the relevance of the data is to the clinical outcome, and then whether what is the source of the data in terms of even the is there a measurable exposure when we are looking at a data, the objective and the measurable, in terms of the appropriateness and validity of the different detailed recordings we want to collect from this. So all this, coming from these data sources, their availability, completeness, and what kind of a design. And I'm mainly talking of retrospective. In that case, we applied some part of prospective to this as well. So we could then, and this was only a few patients where we applied to it. So it was a combination of both. And there was a difficulty in collating all that data, but finally we got a very good data. And to come to the budget part of it, we actually used a budget which was a part of the brand itself, because there was a significant value which the commercial team really saw in terms of getting in RWE out of this. And yes, there are challenges about convincing on certain of these evidence generation and building that how you would go across the spectrum. But we could get this data, and finally we got a very good output in terms of the overall hepatic safety of the drug, and it had a significant effect in the prescribing methods, not only prescribing methods, but even the drug which was being used only by a specific set of specialists or doctors. Actually, after the safety data, the usage spread across to the wider spectrum. So it created an impact on the brand, the impact on the brand life cycle management from the real world evidence. And what we also noticed from RW, as it is seen in some of the very good RWE studies, is also the free prescription of a drug and the usage in patients who are not eligible. Like I'm talking of, though it's not something which you always do it for, but getting an idea about some off-label indications as well. And then using this information, one could go and decide whether a drug would be useful in those other set of indications and other set of patients. So this needs a good proper budget planning. I would say the commercial teams and the medical team should sit down and look at what kind of a real good RWE needs to be designed, and whether the data is captured by from the EMR or modify the EMR to gather the disease specific demographics, and then the prescribing and the drug treatment data. And then how would you want to decide on a retrospective versus a prospective? Prospective may be slightly resource intense, but I think the data which really comes out would give much more quality output in terms of the overall evaluation at the end. So it has a tremendous impact on the overall improvement of the market access, and also the way in which right manner it could be used across the spectrum, and the confidence it creates in the various set of specialists and doctors. What I have seen through this, the exercise we did it for one of the NSAIDs.
This is great. It's very heartening to hear that despite all the challenges of capturing real world data and then doing the studies and the time and the resources it takes, we have seen examples of where this has been successfully done. So it's very good to know, and I think these kinds of examples are going to increase over a period of time. Thank you very much, Dr. Sharma, for your time. It was great to have you here and share your thoughts and share with us some examples from your experience. Thank you very much.
Thank you. Pleasure to be here. Thank you.